Welcome to AETCM, the emergency medicine channel. Today we are discussing about the management of a CLD patient in emergency room and emergency ICU. Whenever a patient comes with ascites, SBP, GI bleed in a clinical settings of cirrhosis, most important things are fluid and salt restricted diet. Salt restriction, we know that normally in a South Indian diet we take around 6 grams of salt. In a patient who is having fluid overload because of cirrhosis, we have to restrict the salt to 2 grams per day. That is very important. Next one is fluid restriction. We can give 1 to 1.2 liters of fluid in a patient who is having cirrhosis with fluid overload. Third one is dietary protein restriction. We have to restrict the proteins like especially animal protein, not normal plant protein, but animal protein should be completely restricted, and a plant protein should be reduced in the early phases of the admission. So these are the three important things we should follow in ICU. One is salt restriction, fluid restriction, and protein restriction. After these three things, we have to go for the drug management of CLD patient. We know that patient is having fluid overload. There are multiple reasons for fluid accumulation in a liver disease. We'll see that, and we can see what is the appropriate treatment for fluid retention in a patient with cirrhosis. There are two drugs, very important drugs. One is spironolactone, other one is furosemide. Furosemide is a diuretic, everyone know that. It removes the fluid from the body. It also removes the potassium from our body. We have to retain the potassium because hypokalemia is one of the major cause for hepatic encephalopathy. So we have to give a potassium sparing diuretic, that is spironolactone, but it's a weak diuretic, so we add furosemide to spironolactone. We can give spironolactone 100 mg per day with furosemide 40 to 80 mg per day. This is the combination we give in all patients who is having fluid overload because of cirrhosis. We know that spironolactone is an aldosterone antagonist. It prevents the potassium loss from the body. So we don't want to lose the potassium in a patient who is having cirrhosis. Hypokalemia is one of the major cause for hepatic encephalopathy. So we give spironolactone. It's an aldosterone antagonist. One of the reasons for fluid accumulation is secondary hyperaldosteronism in chronic liver disease. So it can prevent fluid accumulation, it can remove fluid, it can prevent the potassium loss. Three actions are very important. So it can prevent hypokalemia. We have to add furosemide with spironolactone. So normally we give 100 mg spironolactone with 40 mg furosemide. We can increase the dose depending on the fluid overloaded condition. Target weight loss every day in a patient who is having ICU is 1 kg per day if the patient is having both pedal edema and ascites, and 0.5 kg per day if only ascites is present. So half kg weight loss is recommended if the patient is having only ascites or only pedal edema. 1 kg per day weight loss is recommended if the patient is having both ascites and volume overload like edema. If you have more fluid loss, that will be more dangerous. Patient can again go to dehydration and hepatic encephalopathy. That should be, we should take it as a very serious issue, because if the patient is losing large amount of volume from the body, patient can go to dehydration and it can precipitate hepatic encephalopathy. So two important drugs, spironolactone and furosemide, both should be given as a combination. Furosemide can remove potassium, spironolactone can prevent potassium loss. So furosemide will increase the volume excretion, spironolactone will prevent the potassium loss, and it also prevents the secondary hyperaldosteronism and fluid and water retention. So these are the actions of these two drugs. Now if the patient is having bleeding tendency, we know that patient can have portal hypertension, patient can have thrombocytopenia, so many things can have, and patient can have vitamin K deficiency also in some of the obstructive jaundice. So bleeding tendency should be managed. That is the second part. So first we have managed the dietary part. Next is we manage the fluid accumulation part. Third one is we can manage the bleeding tendency in a patient who is having CLD, portal hypertension, hepatic encephalopathy, all these things. If the INR is elevated, Normally INR will be slightly elevated in chronic liver disease, 1.5, 2 is normal. If it is very high, more than 3 and all, we can manage it with our treatment protocol. Either patient should have a clinical bleeding or an elevated INR. Normally we can take it as more than 3, we can treat the patient in emergency room. Vitamin K can be given 10 milligram IV 3 days. But only remember one thing, it is most effective in a cholestatic jaundice than routine liver disease, because whenever there is an obstructive jaundice, the absorption of vitamin K will be reduced. Fat soluble vitamin K will be reduced. Otherwise, vitamin K will be normal in our body, but even then we can give vitamin K 10 milligram IV for next 3 days, especially in a patient who is having obstructive jaundice. It can be given as IV or IM, but IM will not be preferred in a patient who is having bleeding tendency. IV can be given. FFP is the next option if the patient is having acute bleeding. If the PT-INR is elevated, FFP can be used. Fresh frozen plasma can be given. If the patient is having severe blood loss with shock, we can treat with pooled platelets and blood transfusion. We can give FFP, pooled platelet and blood transfusion. So fresh frozen plasma, vitamin K, blood transfusion with platelet transfusion should be given in a patient who is having bleeding tendency. If the patient is presenting with acute bleeding, acute intra-abdominal bleeding, we have to treat with pantoprazole, 40 milligram IV stat, then BD. We can give it as infusion also, but nowadays the recommendation is pantoprazole, 40 milligram IV stat and then BD, 80 milligram we can give. We can give somatostatin and its analog octreotide. Octreotide dose is 100 gram bolus, then 50 gram hourly infusion. Somatostatin is 250 gram bolus, then 250 gram hourly infusion. Vasopressin can be given. It constricts the splanchnic arterioles. 0.1 to 0.4 units per minute infusion can be given. Adverse effects due to vasoconstriction can be produced by vasopressin. The adverse effects are angina, myocardial infarction, arrhythmias. If the bleeding is not controlled with octreotide or somatostatin or vasopressin, we have to take the patient for endoscopic procedures like EVL and sclerotherapy. So a patient who is having bleeding tendency should be treated with vitamin K, FFP, blood transfusion, platelet transfusion, pantoprazole, octreotide. These are the treatment protocols who is having bleeding tendency in emergency room or ICU. Next one is beta blockers. Beta blockers should be started in a patient who is having portal hypertension. The ideal drug which was recommended previously is propranolol, 20 mg BD. The current recommendation is carvedilol. Both are beta blockers. Propranolol was the recommended drug previously. Now carvedilol is the drug of choice. Carvedilol has mild anti-alpha-1 adrenergic activity. It is an alternative to non-selective beta blockers for portal hypertension prophylaxis. So carvedilol or propranolol should be used for patient who is having portal hypertension. It can reduce the portal pressure. So beta blockers are the next option. If beta blockers are contraindicated due to any reason, patient can be given nitrates, sorbitrate. Nitrates also decreases the portal pressure in patients with cirrhosis. But first line drug is beta blocker, that is carvedilol. Next drug in ICU to prevent hepatic encephalopathy is lactose. It's an osmotic laxative. It reduces the pH in our intestine. It favors the conversion of ammonia to poorly absorbed ammonium ion, so that ammonia can be removed from the gut itself. It can reduce the ammonia producing bacteria also. So it can reduce the ammonia producing bacteria, it can reduce the ammonia, it can prevent the absorption of ammonia. Dose of lactose is, it can be given as syrup lactose 30 to 60 ml every hour until the diarrhea occurs, and we have to at least produce 2 to 4 soft stools per day. Another way of giving lactose is we can give lactose as lactose retention enema 300 to 700 ml in distilled water and can be administered as enema. So we have given diet management, we have given drugs for removing fluids from the body, then we have treated the bleeding tendency. Now we have given lactose to avoid ammonia production and removal of ammonia from the body. Other treatments, like if the patient is having suspicion of SBP, if there is a suspicion of infection, then we have to treat the patient with third generation cephalosporins like ceftriaxone or cefotaxime, because gram-negative infection is the most common cause for SBP. We have to avoid sedatives, NSAIDs, high protein diet, hypovolemia, hypokalemia, hyponatremia in any patient who is having chronic liver disease, ascites, cirrhosis, portal hypertension, hepatic encephalopathy. All these drugs should be avoided. To prevent osteoporosis, that is very common in chronic liver disease and chronic kidney disease, bisphosphonates can be given. Whenever there is large volume ascitic tapping, we have to treat with albumin also. If the volume is reduced very fast, patient can have hypotension. Intravascular volume also can be reduced. Patient can have hypotension and shock. To prevent that, we have to give albumin along with large volume ascites tapping. Transjugular intrahepatic portosystemic shunt can reduce the portal pressure if the patient is having severe portal hypertension and bleeding tendency, which is not controlled with routine measures. Now, when we talk about sedation, anesthesia, anticonvulsants in a patient with hepatic encephalopathy, these things are very common in our ICU. We can use midazolam. It's a short-acting drug. Its single dose 1 to 2 mg can be given in patient who is having cirrhosis. But routinely, this drug should be avoided because it can produce longer effect in a patient who is having liver disease. Haloperidol is a safer choice when we compare with the midazolam. Midazolam is a short-acting drug, but in a chronic liver disease, sometimes it can produce prolonged sedation, and we can get a misleading idea about hepatic encephalopathy. So, better to go for haloperidol. Fentanyl can be given if the patient is having severe pain or if you want sedation. Patients who developed opioid toxicity should be treated with naloxone. That is the only problem. Fentanyl can be given, but remember, if patient go for prolonged low GCS, we have to use naloxone. Propofol is another choice of drug in a patient who want sedation for any procedures like endoscopy. Pain management, remember, paracetamol is normally contraindicated in severe liver disease, but if the patient is having mild to moderate liver disease, paracetamol can be given as a pain reliever in patients who is having liver disease. Tramadol also can be given in patients with chronic liver disease, but all these drugs can produce prolonged sedation like tramadol, midazolam, fentanyl, all can produce prolonged sedation. So we should be very careful when we are using these type of drugs. Seizure is another important complication in patient who is having hepatic encephalopathy. Most of the drugs which is routinely used for seizure prophylaxis or seizure management is contraindicated in chronic liver disease. We can give levetiracetam. That is a very good choice in patients who is having liver disease. Levetiracetam, we can load it as 1 gram, then 500 mg TID or BD can be given. Other drugs, like if the patient is having SBP or susceptible for SBP, we have to give non-absorbable antibiotics like rifaximin. That is very good choice. Previously metronidazole was the choice. Now metronidazole or neomycin was the choice. Metronidazole 250 mg TID, but this produces severe distaste because of the drug. So nowadays we are not using this drug. We can use a non-absorbable drug like rifaximin. Dose is 400 mg to 550 mg TID. That is a dose. L-ornithine, L-aspartate is a liver protective agent that also can be given if the patient is having high ammonia with metabolic, high ammonia with hepatic encephalopathy. L-ornithine, L-aspartate. So rifaximin should be given in all patients who is admitted with susceptibility for hepatic encephalopathy or in a patient who is having hepatic encephalopathy, dose is 550 mg TID. So we have discussed about the management of chronic liver disease and its complications in emergency room and ICU. Thank you.